Hello and welcome to Raider HQ After Dark. I'm your host Raider. And before we get into today's video, I'd like to, thank everybody that's been watching and subscribing and doing all the YouTubey things. I appreciate it. And if you could do more of that and watch the videos throughout if you want to, that would be cool. I'd also like to take the time to thank all the members and the VSRs and all of the great veterans who have been putting some very fascinating and interesting comments in a lot of the videos. A lot of these comments inspire me to want to do videos about them. So keep the comments coming if you could. But today's video is about asthma and bronchial asthma. And we're going to be talking about how is it rated. So we're going to be breaking down the 38 CFR rating scheduler, part 4, about how asthma translates into what percentage it's given. We're also going to be reviewing the DBQ itself. So that way, if you're one of the individuals that are submitting a private DBQ for asthma, you can be as informed as you humanly can to kind of see what it's going to look like and how, things need to be in order to get 10%, 30%, 60%, or even 100% if you are so disabled. And then we're also going to talk about when it's presumptive and what the requirements are for that. And a couple, like just a one-off situation with how asthma can potentially be a reason to grant special housing. Yeah. So that's what this video has planned. So let's go ahead and get into it. So let me share my other screen here. So this is 38 CFR Part 4. And what we're looking at here is the word salad, which is the rating scheduler for bronchial asthma. Now, the thing that you need to understand is that the respiratory body system has a lot of subtle nuances to it. So if very few things have the same criteria in order to grant. So you cannot generalize this. This specific set of requirements are similar to other conditions like COPD, things like that, but they're not exactly the same. Now, bronchial asthma is very unique in the fact that it is much more generous in order to grant because it has a lot of or situations. Some of the other respiratory conditions do not have or situations in them. Now, the first thing that we should probably do is talk about what all of this jargon nonsense is right here. This FEV1, FVC, it's acronym heck, But basically, in order to get service connected for asthma, in order for a DBQ to be sufficient, there has to be what is known as a pulmonary function test, a PFT test. That is a respiratory test that kind of measures the flow of your oxygen, like how well you can breathe in, how well you can breathe out. This is going to be a pretty lay description of it, so don't kill the messenger. Now, these are just values. The FEV1 is a specific value in the pulmonary function test. So is the FEV1/FVC. So as you see, there isn't one that's better than the other. There's a lot of or situations here within this to where, there's no real one path to get the highest rating. It will depend on your specific manifestation in that diagnostic test, the pulmonary function test. And they typically will go with how the most severe thing. So when we go down here, I want to start at the notes because this is important. This is one of the few times where they talk about in the absence of clinical findings of asthma. So in your current presentation, when you go to your CMP examination, if they do not find that you have what they would consider, and I'm air quoting right now, a diagnosis of asthma at the time of examination, A verified history of asthmatic attacks must be of record in order to confront that lack of diagnosis. So basically, what this means is if you have a history of asthmatic attacks, then they should take that into consideration during the examination and just say, okay, well, maybe he doesn't have it at this moment, but it is a thing. It has been historically diagnosed. So that is important. Now, for the 10%, just a diagnosis would be 0%. That's kind of the standard for most anything that gets service connected with just a diagnosis, but no compensable symptoms. So when we start out at the 10% level, reviewing asthma, we're looking at the lab result of FEV1 on the pulmonary function test to be 71 to 80% predicted. Now, I don't know about you, but this is going to probably bore you to tears like it does me. This is just when the rater goes through and they plug in the pulmonary function test. All they do is they have these little boxes that say FEV1, and then you take whatever's on that lab result. Let's say it's 79. Then you would just put 79 in there, and then you would go to FEV1, FEC. There's also a Dalco. There's a few different ones that can be entered, but there's very specific ones that the VA itself cares about in order to determine whether or not you're 10, 30, 60, or 100. So let's say, for example, you had 79 for your FEV1. Well, that for this one would get you 10%. If your FEV1/FEC was 79, you would get 10%. Or if you, and this is, I'm going to be honest with you, this is the easiest way for people like this and this. The easiest way to get 10% is to show that you're on intermittent inhaler, like you're on albuterol and inhaler. And typically what intermittent means to them is if they say PRN, that's what they prescribed you, as needed. So if you're on an as needed bronchial inhaler or bronchial therapy or normal inhaler, that's good enough to satisfy the 10% evaluation. Now, if moving up to the next one, as we can see, the values go down. So as the values go down, that means worse. So less than 70, but greater than 56 or greater is going to be 30%. Same thing over here. These match up, ding for ding here. Or, and now this is also the more common way that I see veterans get granted, daily inhaler. Now, this is the key word, okay? Words matter in the rating scheduler. So if it says must, then that's a true must. If it says and, then it must be there. But daily has to be the way it's prescribed on the inhaler by the doctor. They have to be. Now you come here to this or. This or is different. So daily inhalational or oral bronchial therapy, that this is one thing right here. Now this or separates the inhalation anti-inflammatory medication. So if you have this, that daily requirement doesn't matter for this one right here, the inhalational anti-inflammatory medication. Just having that as defined by your clinician, that it is that type of medication, would satisfy the 30%. Or you would need daily inhalation prescribed by your clinician that prescribed the medication in order to meet the 30% requirement. Now, as we get up here to the 60%, you're going to start noticing it's getting worse. It's getting pretty bad. So down to 40 or greater, or 55 or less. And that goes across the board for these two values, FEV1 or FEV1/FEC. Or, and we come here back to the or, at least monthly visits to a physician for required care for exacerbations. Now, this, okay, I've seen a lot of people try to stretch this to be like they go in with complaints. No, this has to be required by your clinician. So You have prescribed monthly visits, not you scheduling monthly visits, but you have to, this has to be a required intervention for the exacerbations, right? Or we come here to the or intermittent, at least 3 per year courses of systemic. And now this is key. They've limited this to oral and oh gosh, parental, I don't know, corticosteroids. So it can't be, it has to be these two administration methods of the corticosteroids, or it doesn't count. So that's the 60% requirement. Now, and we have no ands yet. So there's no, like, it's or. If you meet any requirement on the or side of it, then you're fine. Now, when we come up here to 100%, right? Now, this is less than 40 for either one of these lab values with the pulmonary function test, or more than one attack per week with episodes of respiratory failure. This will have to be in your medical record. You have to have them qualify that your once a week attack counts as respiratory failure. If you don't meet that criteria, the rater can't, they can't get there to get you to the 100% using this particular or. Now, there will be check boxes in the DBQ to help, guide it. But the main reason why I'm pointing this out and why I'm going to go through the DBQ is because I recommend that each of you go through your DBQs after your rating decisions to ensure that you were accurately evaluated. Now, the or here requires daily use, obviously, of the oral and the P word, high dose. Now, this has caused some confusion in the rating community as to the difference between corticosteroids themselves and high-dose corticosteroids. There's no definition of this. So you would need to, if you were going to go this route with it, you would need your doctor to qualify that the corticosteroids that you are on are high dose. For this, for that particular, you're on a high regimen dose for steroids for your respiratory asthma. Or if you had, now this is another or to where you don't need the high dose on this side of the or, but it would be immunosuppressive medications. They have to be prescribed like that. And they also, anytime you have an or for a specific medication, just being on the medication doesn't count. You have to be on the medication and prescribed for the asthma itself. You can't be like have lupus and have the immunosuppressive medications for the lupus and try to have it count for the asthma. It won't work. That's not the way it functions. So you would need to have the doctor explicitly report that the medications are due exclusively to the asthma in order for you to have it count towards the 100%. I've seen time and time again where veterans, either the doctor wasn't clear or they have a comorbidity where they have two different conditions that require the immunosuppressive medications, and the doctor just, the first condition that required it, that's the one it got prescribed for. And then the doctor doesn't make the distinction that it's used for both. So you would have to follow up with your doctor and have them qualify that the immunosuppressive medications are for both conditions. That would count. That would qualify. You could make that argument and win well often than not, So this is how asthma itself is evaluated by the rater. Let's go ahead and move into the respiratory DBQ, and let's look at what this kind of translates to. So you're going to be a little bit disappointed here because there isn't very much that's going to be in the way of related to asthma on here. So we've got a lot of pages to go through and not a lot of real, it doesn't apply to asthma for the most part. So if you're doing a private DBQ, now I'm going to come from the perception of doing a private DBQ. It has to be all filled out what is required. So the records reviewed have to be specifically stated. It strengthens your claim to have, like, if you're going for service connection and not an increase, and you're using like a private DBQ, they need to cite what records you gave them access to if you're using a private provider. Okay. Now, the diagnosis, we're going to come down here and we are going to say asthma. Okay. This is all that, needs to be checked for the asthma diagnosis. They don't have to put in an ICD code. The date of diagnosis does help though. So if this is your private clinician and you're doing a private DBQ, this can matter for the earlier effective date for the presumption. Like if you were to claim asthma under a presumptive theory for service connection, if you were diagnosed before the date of the liberalizing law change, that can give you a year earlier, up to a year earlier effective date for it, which can matter drastically. So the date of diagnosis, you want to make sure that this is accurate, okay? As accurate as it can be. Just for that back pay, guys. I know it's not a big deal to some people because they just want to get service connected, but it is. You shouldn't shortchange yourself. So sometimes you can have asthma-like conditions like restrictive lung disease. There's certain, I forget, there's synonyms for it. But yeah, so there's a lot of like pleurisy, there's a lot of other conditions. Now, if the examiner were to just write asthma down here, that would also qualify. It wouldn't hurt anything. It's just the examiner being weird. Now, if there are any additional diagnoses that pertain to the respiratory condition, list them down here. The examiner should, on the private DBQ, list everything that the veteran currently has a diagnosis of. If they leave something off of it that is clearly diagnosed, then that causes a confliction. Now, this is important for the private DBQs because the VSR and or more specifically the rater can kick it back going, wait a minute, you gave a whole bunch of testimony here, but you forgot to talk about the veteran's clearly diagnosed sarcoidosis and how that affects the asthma. So keep that in mind, that we have to, everybody's got to be honest and truthful with the private DBQs and make sure that it all matches up with the evidence that, not only that the examiner saw, but that the VA will see. So just keep that in mind. And this is going to be a long one, guys. Now, the brief history, this is important. You want to make sure that this lines up with your evidence, that they don't just, artificially say that, if you got into service in 2010 or let's say 2000, that they don't say that erroneously that your asthma started in 1999. That would cause a problem. That would be a confliction for the rater, because then they'd go, well, wait a minute, if it started before then, that would be aggravation. That's the only way that we could consider it. So slip-ups by the examiner in the subjective comments section here, when they're taking the history, either by the examiner or by you, let's be honest, sometimes we get nervous and we say the wrong thing to the examiner. It happens. You need to be mindful of this, though, because your evidence has to be dress right dress. It has to be true, and it has to be factual, and it has to be consistent, okay? So does the veteran's respiratory conditions require the use of oral or parenteral cortical medications? Now, if you remember, question 2B is important because question 2B is actually for the 60 and the 100%. So this is one of the or situations where we have high dose corticosteroids and systemic corticosteroids. So why did it change? 2B. So question 2B, this is important, right? If yes, they require a low dose, they require an intermittent course, systemic oral. This has to be accurate. So the high dose here, And we're going to, because the DBQ is out of order, guys, I can't really flow with the 10, 20, type 30. This portion, though, does talk about if they require, let me see here, corticosteroids, high dose, therapeutic, high dose, immuno. So if we're talking about the systemic oral, right? Intermittent is the key term for the 60%. So if we're looking for intermittent systemic theories, 3 times more a year. So intermittent requires intermittent course of oral corticosteroids. This is the one that they need to check. And then if you look at it, at least 3 times per year. So it would have to be either this or this in order to be 60%. So this would be required. Now, all 2B, question 2B itself could get you 60%. You wouldn't even need to rely on the PFT tests, right? Because we're dealing with a lot of or situations here. So if you had intermittent at least 3 times per year, systemic corticosteroids, and it is hailing now for some reason, you would, this would do it for you. Either one of these would get you 60%. So if we had, let me see here. If we come here for the, and I don't get what the low dose is, right? So if you look at this DBQ, like this is where it kind of bothers me sometimes, is because I don't know if you noticed, there's no chronic low dose on that on here. There's no low dose, right? There's high dose, there's a normal dose, I guess, but there's no low dose of corticosteroids for this. So I always find that odd, like it's a trick. So you need to, like, this one right here means nothing to the rating decision for asthma. It can for a different condition that maybe low dose has a meaning to that specific condition, but it doesn't have a meaning to asthma. So this is a dead checkbox for you. This is the 60%. This right here is the 100% if you require systemic high dose corticosteroids for control. This is 100% for you. And this is why, actually, it would be daily. I apologize. My bad. So it requires the daily use, not this one. So this annoys me because these two would be the 100% right here. This one would not. This is for a different respiratory condition, to be whatever it would be for a different respiratory condition. And the reason why is because you have to go back here. The words matter. It requires daily use. So you have to have the daily use check box clicked for the high dose steroids. Now, daily use for the immunosuppressive medications, it doesn't have to be daily, but this is the closest one. So these two check boxes right here would need to be checked for you to receive the 100% for these two or situations. And I'm once again going to apologize for the way that the DBQ is done because it makes me go out of order. Does the veteran's respiratory conditions require use of inhaled medications? So this section 2C is where we talk about the situations for the 30 and the 10. So this is intermittent oral therapies. This is daily. So we will do uncheck those. We will do this one first. So if we do inhalation, I can't check it. Wait, yeah, I can. Okay, never mind. Inhalation bronchial therapy, right? That would be the 10% inhalational bronchial therapy on an intermittent level would be 10%. So if you check this and it was intermittent, that would be 10%. However, if they checked daily, that would be 30%. So the 30% is the daily inhalational or oral bronchial therapy. See why this is annoying yet? Now, if we want to go into the anti-inflammatory medication, that's going to be the 30%. But it can be either one for this because there's no daily on this side of the OR. So on this side of the OR, there is no daily requirement. So if you checked this box, it wouldn't matter if it was intermittent or daily, you would still meet criteria for the 30% because that qualifying frequency isn't there. It's a mouthful to talk about this, guys. So moving on down, other medications don't matter because if they don't fall into the inhalational bronchial therapy, it's not going to count. So if they're wanting to put a specific drug down, they still need to qualify for your private DBQ that they're either inhalational or bronchial therapy in nature. So they would have to write that in right here. Sorry, guys. The dogs had to go out. All right. So moving on down. Does the veteran's respiratory condition require the use of bronchial dilators? Well, okay. Bronchial dilators. So bronchial dilation therapy, bronchial dilator therapy. Okay, then. Yes. So this can also be a route. Even though it says it right here, bronchial dilation therapy, it repeats it again and 10% right here. So if this is yes, 10%, 30%. Does the veteran's respiratory condition require the use of antibiotics? And let's see here. Does this one require antibiotics? I don't see antibiotics. And I do not see. So this, if I was rating this, this is how I have to do it. I'd have to review each checkbox to see, and then kind of double, triple check everything. Does the veterans require outpatient oxygen? Oxygen is not a factor in this, right? It's just lab result, frequency of respiratory failure, or the use of this high dose corticosteroids, or immunosuppressive medications. Oxygen is not a factor in this like it is with like COPD. So it doesn't matter if this, why does it keep moving up? It doesn't matter if this is marked yes or no. It won't affect anything unless you have something else. Does the veteran have any of the following pulmonary conditions? Yes, asthma. So if asthma is checked, then we have to, the examiner below this will only fill out part A and the remarks section. So let's go to part A. As you can see, it is a lackluster section of the DBQ here. So part A is, has the veteran had any asthma attacks with episodes of respiratory failure? So as you remember, respiratory failure is in the, why is it doing that? Is in the 100% category, right? We have exacerbations down here, but they specifically cite respiratory failure, and you need 1 attack per week. So in order to qualify, why does it do that? In order to qualify for it, you have to come down here and mark yes, the number of attacks per week. So you would need at least 1 attack per week in the last 12 months. So, yeah, that's how you could also get to 100%, you know, respiratory attacks, respiratory failure 1 time per week would equal 1 attack per week, respiratory failure, 100%. And we're going to come back here and, oh, it's stuck. Okay, good. Has the veteran had any physical visits for required care for exacerbations? So question 1B talks about the 60% requirement. And I don't know if you're still tracking, but this is all over the place for a rater to have to review. Exacerbations. So at least monthly visits is required for 60%. If you have no, like, it's only mentioned 1 time here. So you have to meet this requirement in order to get the 60%. So if yes, describe the frequency. At least monthly would have to be checked for the 60%. And then we come down here. we're going to scroll down, 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 scroll down. And we're going to go to the diagnostic section. Pulmonary function test. So this would have to be marked yes. And then we come down here and the date of the test has to be in here for all of you guys with the private DBQs. The date of the test has to be on there. And then what happens is they will fill this out. So FVC, FEV1, FEV1/FVC, DLCO. This is the pre-bronchial dilator, and then this is the post-bronchial dilator values. So the rater would input these percentages into VBMS-R when they rate, and then it'll spit something out. Now, what's important is this next question, 4D. Which of these tests right here, actually, which one of these values right here, which one of these tests accurately reflects the veteran's level of disability? Okay, so if they pick FEV1, then the computer, we will select that button, and then the computer will use the value for FEV1% predicted in determining what, where you fall on this value, right? It'll depend on what the evaluator says. So just keep that in mind. So if the examiner says DLCO, well, I mean, that kind of puts you at a disadvantage because DLCO is not a lab finding on here to review for, right? So you can't be 10, 0, 20, 100, doesn't matter. DLCO isn't on here. So it's just kind of weird. So be mindful of that if you're doing a private DBQ, they can't pick this one. They probably shouldn't even pick, they should only pick FEV1/FVC or FEV1. So FEV1 or FEV, this one or this one. They should pick either one of these two, which one's worse, for the value. Because if they pick either one of these two, well, those aren't represented in the 38 CFR, so it doesn't really help you any at all. So the rest of this is pretty much for other conditions. Functional impact has nothing to do with your IU determinations. I just want to say that. Now, the final thing on here is remarks section. This also has to be dress right dress. It cannot be conflicting with any of the information. It's like, yes, he requires, he's taking these steroids, but yeah, they're not high dose. It has to match. All the check marks above have to match what the examiners say. And then finally, for the private DBQs, all of this has to be filled out and it has to be accurate. The National Provider Index number, I would go look that up and make sure everything's current and up to date, because if you're using a private DBQ, the VA is looking to see if all of this information, the medical license number matches up with the state, the National Provider Identifier number matches up with, if that's updated and current. Because examiners can get behind, they cannot update that, and it'll be deemed as fraud or inauthentic, and the VA will toss the DBQ if the National Provider Index number on the website, if their information doesn't match what's here. So the fax number, the address of the current business, things like that. I know we're at 33 minutes, guys. I'm trying. So one of the other things I wanted to talk about is, what is asthma presumptive for? Well, asthma is presumptive for fine particulate matter exposure. So that has to do with exposures in Iraq, Afghanistan, any kind of burn pit exposures. So as you can see here, asthma is a presumptive condition. So this is Persian Gulf, Southwest Asia, theater of service, Afghanistan, Syria, Djibouti, Uzbekistan after 2001, also Persian Gulf. This is all the information for it. I've talked about, I think I've done a video so far on 38 CFR 3.320. But this is what it's presumptive for. Now, why does this matter? It matters because August 10th, 2022 is when the burn pits was added to the 38 CFR 3.320 theory for service connection. That means if you were diagnosed before August 10th, 2022 with asthma, you meet criteria for a year earlier effective date. Or if you've been denied before, but you are continuously pursuing it, the earliest date that you could get using the PACT Act would be August 10th, 2022. But if you filed, like, let's say today, and you had a diagnosis back in like 2015 of asthma, we would give you a year prior to either your intent to file or your date of claim on your claim. You should deserve it. If you were diagnosed back then and you get granted under this theory right here, that's the way it should be. Now, the final thing that I want to talk about here is special housing adaptation, SHA. I think that's the one. So one of the things that if you are diagnosed with asthma at 100%, so you meet the scheduler criteria under this category right here, then you are a veteran who is explicitly determined to be eligible for this particular benefit, the special housing adaptation, because it says it right here: residuals of an inhalation injury included but not limited to asthma at 100%. And where I'm getting the 100% is from here. PNT. The PNT, you have to be 100% disability from asthma would get you pre-qualified for the special housing adaptation. So that's about all I got for you today for the asthma. How is it rated? I'd like to thank you guys for sitting with me for 36 minutes. It's probably been just torturous. But, not every one of these is going to be a banger. But, I just want to put the information out there so that way, if you do need to file this in the future, you kind of see how it's rated. Okay. So that's about all I got for you guys today. Like, subscribe, like I said in the front of the video. Thank you to all the Raiders and the VSRs. You guys are awesome. I appreciate you so much. And don't mind my being on hold call today to Doug Collins. That just drove me nuts. But sorry for the late video, but that's why. Anyway, guys, Raider out.